The mission of the Prevention Health Promotion Administration is to protect, promote, and improve the health and well-being of all Marylanders and their families through provision of public health leadership and through community-based public health efforts in partnership with local departments and providers, community-based organizations, and public and private sector agencies, giving special attention to at-risk and vulnerable populations. The Prevention and Health Promotion Administration envisions a future in which all Marylanders and their families enjoy optimal health and well-being.
Thank you. Good afternoon, everyone. Today we're going to review data from the 2015 Maryland Behavioral Risk Factor Surveillance System. You will also hear me refer to as the BRFSS. The BRFSS was established by the Centers for Disease Control and Prevention, also known as the CDC, in the early 1980s out of a desire to capture population prevalence of chronic health conditions, behaviors, and use of preventive services in the U.S. adult population. After a couple years of testing out methodology, BRFSS was launched in 1984 with 15 states. Maryland joined the BRFSS in 1987. This became national within a few years and are now collected in all 50 states, the District of Columbia, and 3 U.S. territories. Weighted by the CDC using a statistical procedure called iterative proportional fitting, which is also known as raking. Through this methodology, demographic differences between survey respondents and the general Maryland population of adults are adjusted for. This is important because it allows us to make statements about the health of Maryland residents and not just about survey respondents. They are self-reported and they are not verified by comparison with medical record information. The survey excludes adults living in institutions such as nursing facilities, group homes, and prisons. This is important to remember because for some outcomes, living in institutions may have higher or lower prevalence of the behavior or condition than people who are living in institutions. One I'd like to mention is that sometimes data are not available even though they were collected. This happens because the CDC requires that BRFSS data are suppressed when they are based on fewer than 50 survey respondents, or the relative standard error is 30% or greater, which indicates a high degree of data instability. Right into the data on cognitive decline. Cognitive decline is assessed in the BRFSS by asking survey respondents aged 45 and older, during the past 12 months, have you experienced confusion or memory loss that is happening more often or is getting worse? The cognitive decline module includes 6 questions that assess prevalence of cognitive decline, the impact of cognitive decline on a person's life, a person's ability to get help when they need help, and whether or not they communicated their concerns about cognitive decline to a healthcare professional. About 6,000 Maryland adults were asked this module in the 2015 BRFSS. About 230,000 Maryland adults aged 45 and older reported experiencing confusion or memory loss that was happening more frequently or was getting worse in the past 12 months. This represents 10.6% of Maryland adults aged 45 and older. There were significant differences in experience of confusion or memory loss by gender, age group, or race ethnicity for those groups were able to report. Data Hispanic, Asian, and other race ethnicity had to be suppressed. In income, we see a different picture. Those annual household income of less than $25,000 reported cognitive decline significantly more frequently than the statewide average. In fact, we see the prevalence of cognitive decline decreasing with increase in income. 22% of those with an income less than $25,000, just under 7% of those with an income of $75,000 or more. That is a significant difference. There is a significant association between disability and cognitive decline. Disability is defined in the 2015 BRFSS by a series of questions assessing 5 types of disability: cognitive, mobility, vision, self-care, and independent living. Disability was not collected in the 2015 BRFSS. For this analysis, if a respondent said yes to 1 or more types of disability, we said a disability. And if a respondent said no to all 5 types of disability, we said they did not have a disability. 30.5% of people with a disability reported cognitive decline. In contrast, 3% of those without a disability reported cognitive decline. That is a significant difference, and those numbers are also both significantly different from the statewide estimate. Some of you are wondering if the prevalence of cognitive decline is so high among people who have a disability because disability, as defined here, includes cognitive disabilities. So let's use data broken out by disability type. When we look at disability by type, we see that, not unexpectedly, 60% of residents with a cognitive disability experience cognitive decline. And that's significant. We see significantly higher prevalence of cognitive decline among people reporting each other type of disability. 20% of people reporting a mobility disability, 50% of people reporting a vision disability, 41% of people reporting a self-care disability, and 40% of people reporting an independent living disability. This graph has a lot of information on it, so let me take a minute to explain what's going on here. BRFSS survey respondents who said, yes, I've experienced cognitive decline, were asked some follow-up questions. They were asked how often confusion or memory loss interfered with their ability to work, volunteer, or engage in social activities outside the home. They were also asked how often they have given up day-to-day household activities or chores like cooking, cleaning, taking vacations, driving, or paying bills. They were asked how often they need assistance with day-to-day activities. Now, we can use these as three separate outcomes, or we can also look at them collectively as functional difficulties. This depicts data in both ways. Well, the 2015 BRFSS data is that 86% of Maryland adults with cognitive decline said that it sometimes, usually, or always interferes with work or social activities. 36% said that they have given up day-to-day chores because of their cognitive decline, and 30% said they need assistance with day-to-day activities because of cognitive decline. For those who have a lot of detail, the bars on the graphs indicating these outcomes include both medium blue and light blue portions. Those medium blue portions represent people who said cognitive decline sometimes caused that issue for them, and the light blue portions represent people who said cognitive decline always or usually caused that issue for them. For each of the issues, about 20% of people said sometimes, and upwards of 10-15% of people said usually, always. Now, there's obviously some overlap between people who said yes to these three questions. That's where that dark blue bar on the right comes in. This bar represents Maryland adults with one or more of these functional difficulties. And we see in Maryland, 50% of adults with cognitive decline were experiencing at least one, if not more, functional difficulties. Students who said that they sometimes, usually, or always need help because of their cognitive decline were asked how often they were able to get the help they need. 7% said always or usually, 9% said sometimes, and 24%, which is about 1 in 4, said rarely or never. Now, to point out, these confidence intervals are pretty wide. So what we're saying is we're 95% certain that the true prevalence is somewhere within that wide range. Survey respondents with cognitive decline were also asked if they or anyone else discussed their confusion or memory loss with a healthcare professional. And half of them did not. It's important because, see on the next slide, Maryland adults who reported cognitive decline have significantly higher prevalence of anxiety disorders, depressive disorders, asthma, COPD, and cardiovascular disease than people who did not report cognitive decline. It should also be noted that the prevalence of cancer, diabetes, and high blood pressure also appears higher among people reporting cognitive decline, though those differences are not significant.
So what can we see from this? One, cognitive decline is experienced across every demographic. There was no significant difference in the percentage of demographics who experienced cognitive decline. This is across gender, race and ethnicity, and age groups. Cognitive decline can happen to anyone, and this is an issue that needs to be addressed across every community. Cognitive decline is significantly higher in those with lower incomes. About 1 in 5 adults aged 45 and over who make less than $25,000 in their annual household income report cognitive decline. The cost assessing care, including health care and travel costs, can impact this population seeking the support they require. 1 in 3 adults living with a disability report experiencing cognitive decline. This presents potential issues for managing self-care as cognitive decline worsens if these individuals are not receiving the proper access to accommodations for support. Individuals who report cognitive decline, the prevalence of several chronic diseases is significantly higher. Disorders, anxiety disorders, asthma, COPD, and cardiovascular disease are significantly higher. Cardiovascular disease in particular places an individual at increased risk for more severe issues relating to cognitive decline, such as forms of dementia. With the prevalence in this chronic condition being significantly higher, it suggests there's a need to address risks earlier in the lifespan to implement preventive measures addressing all chronic diseases. Facts. 1 in 3 adults with cognitive decline need to give up day-to-day household activities or chores as a result of confusion or memory loss. This suggests that a person's ability to perform activities of daily living is influenced by cognitive decline. Examples include communication, transportation, shopping for and managing meals, housework, managing vacations, and managing personal finances. Individuals may not always be able to get the support and assistance that you need. Among those who need assistance, fewer than half were able to get the help they needed. The inability to manage self-care can lead to further complications in health. And half of adults with cognitive decline report their health status as fair or poor. This combined with an inability to get needed assistance is concerning, as the population's health could continue to decline, which may put them at increased risk for comorbidities. So, what are the best practices for cognitive decline? Making primary care appointments. If the individual maintains regular appointments and being open about issues, this will assist primary care physicians in developing proper treatment protocol. Assess cognitive impairment in older adults, and in earlier assessments to patients. Per the National Institute on Health assessing cognitive impairment in older patients, if assessments are negative, concerns may be alleviated, at least at that point in time. And if assessments are positive and further evaluation is warranted, the patient and physician can take the next step of identifying the cause of impairment. That may result in treating the underlying disease or health condition, managing comorbid conditions more effectively, averting addressing potential safety issues, allowing the patient to create or update advanced directives or plan long-term care, and ensuring the caregiver receives appropriate information and referrals. Implement and effective care planning services. We said, care planning is important. In January 1st, 2017, Medicare now provides reimbursement to clinicians for care planning services provided to individuals with cognitive impairment. Also, the legal and financial planning through the Alzheimer's Foundation has allowed individuals to establish plans for themselves in their future care. The Alzheimer's Association partners with experts in Maryland to administer legal and financial planning sessions, and Alzheimer's Association training curriculums to guide individuals through legal and financial planning processes, including reviewing terms and processes which individuals may find unfamiliar. And legislation here in Maryland has also influenced care planning, with the passing of House Bill 188 that states that a witness is not required for an advanced care directive provided the individual's identity has been authenticated in accordance with certain guidelines. The department here will issue and may contract with one or more electronic advanced directive services who will adhere to these guidelines and be recognized by the Maryland Healthcare Commission. Why are planning important? Legal and financial planning enables an individual to express his or her wishes in decisions about future care. These wishes can be expressed through advanced decision-making or by appointing another person to make decisions. This can be troublesome for families and healthcare providers who may need to address urgent care issues when no plans have been put in place. Planning assists individuals with cognitive decline in these areas as future care may be impacted by their condition worsening. So, if time for questions on cognitive decline, if you send them in by chat, we have some time to take them before we move forward in our caregiving presentation. Any questions, then we will move forward in our presentation, and Georgette will begin her discussion on caregiving.
Thank you. Now we're going to switch gears a little, talk about caregivers. BRFSS survey respondents were asked, during the past 30 days, did you provide regular care or assistance to a friend or family member who has a health problem or disability? The schedule includes 9 questions to assess the prevalence of caregiving, the relationship between the caregiver and the caregiving recipient, the major problem, illness, or disability of the caregiving recipient, the time investment in caregiving, the care provided, and unmet needs of the caregiver. About 6,000 Maryland adults were asked this module in the 2015 BRFSS survey. According to 2015 Maryland BRFSS data, 976,000 adult Maryland residents are caregivers, and 450,000 expect to become caregivers in the next 2 years. The data here are for those residents who are currently caregivers at the time of the survey. The 15 Maryland BRFSS data indicate that 24%, or about 1 in 4, Maryland adults was a caregiver. While we see some variation across demographic groups, there are no statistically significant differences between any of the presented demographic groups and this wide estimate. We see difference by gender. For race ethnicity, we see apparently low prevalence of caregiving among Asian and Hispanic residents, and an apparently higher prevalence among other race ethnicity compared to non-Hispanic and non-Hispanic. But those differences, we also see apparently higher prevalence of caregiving among younger-aged adults, age 18 to 34, and age 35 to 54 and 55 to 64. Apparently lower prevalence of caregiving among adults aged 35 to 44 and 65 and older. But again, these differences are not significant either. We see apparently decrease of caregiving with increasing income, but again, that is not significant. And we see what appears to be higher rates of caregiving by people with disabilities than by people who do not have disabilities. But as demographic variables, these differences are not significant in this analysis. 12% of caregivers are taking care of a parent. 12% are taking care of a husband or a wife. Almost 10% are taking care of a child. 8% are taking care of a sibling or brother or sister-in-law. Almost 8% are taking care of another relative. 11% are taking care of a grandparent. And 45% are taking care of a mother or father-in-law. Some are taking care of grandchildren, though those data are suppressed. So the are taking care of a family member. For 12%, or about 1 in 8 caregivers, are taking care of a non-relative or family friend. The health problem, illness, or disability of the caregiving recipient varied widely. 10% had cancer, 8% had dementia or a cognitive impairment disorder, 6% had a developmental disability, 6% had some form of arthritis or rheumatism, 6% had heart disease or hypertension, 5% had diabetes, just some 3% had chronic respiratory conditions, and some adult folks had other organ failure or disease, mental illness, and asthma, but data had to be suppressed. Almost half, 46%, had something else that was not on the list. So there are a number of different conditions affecting the population of caregiving recipients. Care asked how long they have provided care for their caregiving recipient. 20% said less than 30 days. 13% said 1 to 6 months. 6% said 6 months to 2 years. 16% said 2 to 5 years. And 30% said more than 5 years. Kids were also asked how many hours of care they provide for their caregiving recipient in a week. 57% said up to 8 hours. That means that 43% were providing more than 8 hours of care per week, which is the equivalent of more than a work day. 10% provided between 9 and 19 hours of care per week. 14% provided 20 to 39 hours per week. Another 16% provided 40 or more hours of care per week, which is equivalent of a standard work week or longer. also asked if they provided care for their caregiving recipients by managing personal care, such as giving medications, feeding, dressing, or bathing. They were also asked if they managed household tasks, such as cleaning, managing money, or preparing meals. 50% said they managed personal care, and 8% said they managed household tasks. There is overlap, of course. When we look at both types of care provided, we see that about percent managed personal care and household tasks. Percent managed personal care only. 30% managed household tasks only, and 6% did not manage personal care or household tasks. Finally, caregivers were asked, of the following support services, which one do you most need that you are not currently getting? It's about giving care, such as giving medications, helping access to services, support groups, individual counseling to help cope with giving care, respite care, or you need any of these support services. 11%, or about 1 in 9, said they most need help in getting access to services. 2% said they need respite care. Unfortunately, data for individual counseling, support groups, and classes about giving care had to be suppressed. But we see that 78% said they don't need any of these support services. We're noting that the prevalence of anxiety disorders, depressive disorders, asthma, COPD, cancer, diabetes, cardiovascular disease, and blood pressure all appeared higher among caregivers than among non-caregivers, but those differences were not significant. What we say for sure is that caregivers are not experiencing lower rates of these conditions compared to non-caregivers. So while they may not be statistical significance, there is public health significance, noting that caregivers are often managing their own chronic health conditions while providing care for their caregiving recipients. And since the main topic today was cognitive decline, I would also like to show you those stats as well. What we see for cognitive decline is that 12% of caregivers reported cognitive decline compared to 10% of non-caregivers. These are not statistically significant, but there may also be public health significance in noting that 1 in 8 caregivers is experiencing cognitive decline while providing care for their caregiving recipient.
So what from caregiving? Common across various populations. Regarding gender, race and ethnicity, age, or income levels, caregiving is represented in each demographic. Caregivers are currently living with a disability. As addressed earlier, if individuals are not receiving the proper access to accommodations for support, they may not be able to provide proper care to others. One, caregivers are reported experiencing cognitive decline. Individuals who are experiencing confusion or memory loss may experience difficulties managing household or personal care of another. One in caregivers provide care for a parent is significantly higher than any other group, and 1 in 8 caregivers providing care for a non-relative or family friend. This is important to note. Caregiving is not just a family issue. Let's look at the time impacts of caregiving. 1 in 4 caregivers have provided care for less than 30 days, and 1 in 4 caregivers have provided care to someone for more than 5 years. There is a significant drop-off in the percentage of individuals who provide care less than 30 days and those who provide care 1 month to less than 6 months. With almost a third of caregivers providing care more than 5 years, the data suggests that the condition of individuals improves quickly or requires care over extended periods of time. Caregivers provide care 20 or more hours per week. With time needed to provide care and work full-time, this may present potential concerns to the caregiver in managing their own personal wellness. Although those that cannot work more hours may also experience financial strain. Almost half of caregivers manage both personal and household tasks. For these caregivers, these tasks include providing companionship and social activities, providing help with shopping, assisting with meal preparation, providing transportation to appointments, household chores, managing medications, perform complex medical tasks such as administering insulin, and planning schedules. The demand caregivers may cause stress as they try to balance caregiving and their own personal lives. So how can we support caregivers? The Maryland Department of Human Resources Respite Care Program. This program provides financial assistance to pay for short-term periodic care to individuals with developmental or functional disabilities. Its purpose is to provide a period of rest and renewal to family caregivers while also providing benefit to the care recipients. The Family of Caregivers Support Program. This is administered by the Maryland Department of Aging and provides support to caregivers caring for someone older than age 60 and grandparents and other relatives over the age of 55 who are caring for adult children with disabilities. Assistance includes information and referral, education, training, rest care, and supplemental services. And Dementia Caregiver Center. The Alzheimer's Association provides online tools for caregivers of individuals facing severe cognitive-based issues such as Alzheimer's and other dementias. And the Caregivers Support Coordinating Council. Established in 2001, the council works to identify the needs and challenges faced by informal family caregivers for those across the lifespan, advocating for and empowering through policies that support them, and making recommendations for the coordination of services. Also, here at the Center, we have other resources. BeHealthMaryland.org is now a one-stop resource for Marylanders seeking information and support on chronic disease prevention and management, and links to classes and workshops, as well as regularly updated chronic disease news bits. Also, we've included a screenshot here, and you'll notice in the quick links, there is a link for cognitive health. If you click on that link, cognitive health, it will take you to our page, which has information on the various activities and our partners that we're working with within cognitive health. We'll open it up if anyone has any questions, either on caregiving or those that they thought of from the previous cognitive decline module.
Were there data on the quality and quantity of sleep among the caregivers?
Sleep is collected in the BRFSS. It was not analyzed in this analysis, but that would be an interesting question to look at. I'll certainly make note of that. Thank you.
A question then on how to be connected to the caregiver support services. The Maryland Department of Human Resources Respite Care Program would be through the Human Resources, and I would check through there in their site. Also, the Family Caregiver Support Program through the Maryland Department of Aging, which you could go there. Alzheimer's and Caregiver Center is actually an online resource, and that is at alz.org/care. Is there any questions? About the legislation on advanced care planning and our role in implementing. So the legislation that was passed is relatively recent, and we are in the initial stages of looking at that right now. So I do not have a great deal of information. This is new for our department as well, but as more information becomes available, I'm sure we will be able to share that out. So payment was that it seems the most significant statistic that we mentioned was the effects of low-income families and the most. Is that correct?
So there were significant differences by income for cognitive decline. Footnotes just to make sure I'm not misspeaking. But with cognitive decline, we did see a very dramatic response sort of relationship with income. With care, we did not see that change, that association. But the cognitive decline, the biggest difference that we saw by demographics was with disability.
How do we make this more accessible to them, considering they are most likely not to be educated or informed in regards to the needs they are? So it's more of outreach and working with those community organizations that would particularly work with individuals of low incomes. And in those brackets right there, you would try to partner with them to give them the education that they would need so they're able to better support themselves. And we suppress to see such a low need for respite. Care supporting council saw a much bigger need.
Right. So I would say the question about what the unmet needs of the caregiver, they were asked which one of the listed needs that they most need. So if there's something that they needed in addition to respite care, one possibility is that they listed that instead. So respite care may be a secondary need to other listed needs. But another thing that I would like to mention, I can't really explain the way of this because we only have the data as they are collected, and it's not an open-ended survey. We can't really people to ask why, but the data are being collected again in 2017. So we, moving forward in about a year, we should have additional data available on specific questions. So hopefully we'll have them able to make more sense of the answers.
So I will just echo what Georgette was saying. I think right here, this information, it lends itself to discuss the need for awareness and the need to be starting to look at that. As we get more data, we'll have a stronger idea of where we're trending to and what we may need to start to address. But for now, I think these bring up some good talking points of what we might need to do within our organizations and health systems and with community organizations, or even those in social supports and ones to really help as well. Thank you everyone for attending. I do apologize for our technical difficulties earlier on. If you do have any other questions, we're able to address. We available through our contact information is available through the Maryland site that's listed at phpa.dhmh.maryland.gov, and we're in Center for Chronic Disease Prevention and Control. And we are posting this webinar hopefully soon to our website, and which will also be having access as well to the slides and information for anybody that wishes to move forward. For your time today, and everyone have a great day.